AWE 2026, and we're actually doing something that we haven't done before. We're so fortunate to have Melissa D'Souza, who is a surgeon.
Yes, a surgeon with a focus in Barrett's esophagus and esophageal cancer.
Oh my God, it's like, I could never understand, and you're at Hoag.
I'm at Hoag.
At Hoag, and I could never understand, and I think Hoag, and I'm very fortunate in my institution, we have a great relationship with our surgeons, and the same at Hoag. And that is the sign that we're standing next to each other and discussing a very important topic to both of us is a sign of that, because we cannot work without each other.
Right, exactly. And I think especially with Barrett's, we know that Barrett's is our only known precursor to esophageal adenocarcinoma. And so many patients are at risks. We know that chronic GERD is the primary driver of it. Obesity, Caucasian, age over 50, smokers, all of these people are at risk for having Barrett's esophagus. And when we find the Barrett's, we say, all right, we've found it, but
what are we going to do about it?
What are we going to do about it? And I think that's where a lot of the discussion has been, is how often do we survey? What are we looking for? What can we use to guide us? Traditionally, length of Barrett, so a segment that was 3 centimeters or more, central obesity, again, age, smoking, all those other risk factors were the things that we were worried about for risk of prevention, because of patients who have Barrett's, only 0.5% per year are going to go on to have progression of disease, develop high-grade dysplasia adenocarcinoma.
But there is so much anxiety, patient anxiety associated with it. And we all know the studies that show that, insurance premiums go up and all sorts of things. So what do we do, and what are we talking about to help with that?
Yeah, so I think one of the greatest things that we have now, and we're here talking about TissueCypher, or TSP9 as it's also known. This is a biomarker assay that actually leverages artificial intelligence as well to figure out which of those Barrett's patients are the ones who are actually going to go on to develop high-grade dysplasia or adenocarcinoma. Traditionally, we relied on, do they already have dysplasia, low-grade dysplasia, but not everywhere has an expert GI pathologist.
No.
Sometimes that low-grade dysplasia
it's not low-grade dysplasia.
It's not low-grade, it's high-grade, or it's nothing at all.
Exactly.
And there, again, the anxiety you're talking about with patients. Right. So what TissueCypher does is it allows us to take that biopsy of that Barrett's metaplasia. We can send it off and risk stratify it, give patients an individualized 5-year risk assessment score. So anybody who has non-dysplastic Barrett's esophagus, low-grade dysplasia, or they're indefinite for dysplasia, you can send off their particular sequence and determine how likely are they to get high-grade dysplasia in that 5-year period. So the TissueCypher gives you back a score, low, intermediate, and high. Those patients who are at high risk for progression, we see that almost 60%, 58% risk for progression to high-grade dysplasia or intramucosal adenocarcinoma within 5 years. That's a patient you're going to want to see more frequently. Exactly.
And maybe treat or ablate or whatever you need to do for that.
And the other nice thing about TissueCypher is because it's based off of the genetics, we have a field defect that we can see. Yes. So anywhere along there, say you have a patient who has long segment Barrett's esophagus, all biopsies, Seattle protocol, have come back, non-dysplastic. But you say they have a high risk for progression.
Yes.
That could be prevalent disease. There may already be disease in there. Prompts repeat endoscopy, use all your other tools in order to be able to try to find the area of dysplasia. If it comes back low risk at any point along there, then you say, all right, this may be stable Barrett's. We don't necessarily have to follow it as closely as we would before. So I think that's actually a huge benefit. It really is going to help us figure out who fits into our guidelines for screening. It's especially hard to tell somebody when they have a 9-centimeter segment of Barrett's, come back in 3 to 5 years.
And they're 35.
Right? It's very different. But on the other hand, the other thing that I have seen in my own patients when we've gotten a TissueCypher score is the people who have ultra short segment Barrett's.
Yes.
It is 1 centimeter, it is not much. some of those patients are coming back at high risk.
That's right.
And I would not have brought them back within
Yes.
kind of that 3-year time period before. Now those patients, I'm getting a repeat endoscopy. And I'm discussing with some of them, is ablative therapy kind of in a prophylactic manner
Yes.
helpful for high risk for progression?
Oh, for sure.
So it really helps guide the discussion and really helps us to see what we need to do for these folks in their future and keep them from getting cancer is really
And
the
I
key.
think we all of us who see patients with Barrett's and scope them regularly, we would have known that the lengths, I'm sure it is a predictor, but it's not a perfect predictor. And we see patients who come up with very short segment of Barrett's with high-grade dysplasia or cancer. And now hopefully this gives us guidance how to approach them. I think the question always comes, when you take biopsies and you send them for TissueCypher, is the specimen needs to be handled in any different way?
No, what's actually
That's the
really
beauty of
what's
it.
actually really nice is you send it off to your pathologist. You can fill out your sheet to request TissueCypher. Say Barrett's wasn't on your differential necessarily. You had, a centimeter of what maybe could have been
Maybe
some columnar
not.
changes.
Yeah.
The pathology comes back as intestinal metaplasia. You can then retroactively reach out, get a TissueCypher score on that patient. So that's also really helpful too. Where
You're not bringing the patient back to
you
do
don't need
that
to get
assessment.
another biopsy. Exactly. You can do it on what you already have, send it to pathology like you usually would, and they're complementary, which is great.
So when you do the evaluation and screening of patients with Barrett esophagus, do you routinely send it, or kind of put it on hold if that comes back to be Barrett's?
Yeah. If I see intestinal metaplasia
Yes.
on my biopsies in the esophagus, I send it for TissueCypher every time. It's just such a helpful prognosticator for their risk for progression, and I don't have any other tool that does the same.